Welcome back to Between Two White Coats, a podcast designed to help you be the healthiest version of yourself. I'm Dr. Michelle Plaster, a family medicine doctor.
And I'm her co-host, Amber Foster, a family nurse practitioner. In our combined 30 years in medicine, we've seen a lot.
We're discussing key issues surrounding health and wellness, answering some of our biggest questions, overcoming health obstacles, and giving patient-centered advice in hopes of educating you and providing the tools you need to live a healthy life.
If you find our podcast helpful, please consider subscribing so you don't miss an episode. And don't forget to leave us a 5-star rating and review. This will help other people find our podcast.
Thanks for joining us. We look forward to serving you.
Welcome to Between Two White Coats. Today we have Dr. Juan Lacayo again with us. Today we're going to be discussing the differences of sleep apnea, the different types, I should say. There's central sleep apnea and obstructive sleep apnea. So most patients or people are familiar with obstructive sleep apnea, but neurology is actually the specialty that deals with central sleep apnea. So we're going to talk to Dr. Lacayo about that today.
So, Dr. Lacayo, thank you for being here. Can you explain to us the difference between obstructive sleep apnea and central sleep apnea?
Yes, thank you. Obstructive sleep apnea is when we're not getting enough airflow into our body, where something's blocking it in the back of our throat, not letting that air go from the outside into our lungs. Central sleep apnea is when the brain itself is not getting the signals like it should be getting and maybe not sending out the signals that it should to the muscle that moves, the diaphragm that kind of expands so that we suck in air and then blow it back out. There's a system that is involved in taking care of that that is neurological in origin and dysfunction.
So obstructive sleep apnea, I think most people are familiar, and when they say sleep apnea, many times what they're thinking of is obstructive sleep apnea. It's very common. It's more common in people who are overweight. And as Dr. Lacayo said, many times when our neck has extra weight, it will block our airway. And so people who are at risk of obstructive sleep apnea would be people with increased neck size, and people who are obese. The symptoms of obstructive sleep apnea, or really sleep apnea across the board, would be feeling sleepy during the day. We have discussed on other podcasts the Upworth screening tool that we use in our clinic to help identify people who may be at risk of sleep apnea to see whether people need to be tested. And a lot of questions on that have to do with how sleepy you are. If you sit still for long enough while watching a movie, if you sit still after lunch, if you lay down after lunch, what are the odds of you falling asleep? Do you ever fall asleep while driving your car? And so when you look at the odds of you nodding off or wanting to nod off or feeling sleepy, getting what seems like 8 hours of sleep and waking up sleepy, sometimes people wake up with headaches. What am I missing on it? Yes, of
most
course.
People, a lot of times I'll get patients who they're like, my wife made me come because we can't sleep in the same room. I'm gasping, I'm snoring, I'm waking her up all night. So I say, if mama's not happy, nobody's happy. So
Right.
I'm here to get screened for that.
Right.
So a lot of times snoring is a big one, just simply because it's aggravating to the other family members that might be sleeping in the home.
Yes, and you mentioned gasping, where sometimes people will wake up and feel like they're trying to catch their breath. Or people will hear them kind of, their partner will hear them snore and then kind of stop snoring and then do and then break back into snoring. And so these are times where people are stopping breathing in their sleep. And so people are more familiar with obstructive sleep apnea. Statistically, a large portion of our American society has sleep apnea. And so tell us about obstructive sleep apnea versus central sleep apnea, which I think people are much less familiar with.
Fortunately, central sleep apnea is much rarer. The obstructive sleep apnea is oftentimes where we may have a little bit extra weight on board. When we're falling asleep, we have a little bit of tone, like a little bit of stiffness in our limbs, and our tongue in the back of our throat. The deeper we sleep, and deep sleep's the good stuff. If we don't get that, or it gets interrupted, then we don't get refreshing sleep. We're always going to be a little bit tired. But the deeper to sleep, the limper your body gets. That's like small kids get into it easily when they fall asleep and you pick their arm up and it
You're
drops
like
back
trying to
down.
fall out. It's like
You
the
know.
Disney World sleep. You can't, you're like dragging them all
That's
over the place.
That's right. With adults, a little bit harder. It takes a little bit longer to get there. But when they're getting there and their body goes limp, their tongue goes limp, and their soft palate, that little thing that hangs at the back of the throat, and you go, ah, that all that kind of falls back on itself and collapses. And the more weight we have on board in our bodies, the narrower our airways get. So obesity does tend to have a high risk of being associated with sleep apnea. Some people's just anatomy makes it where their jaw might be smaller, the top of their mouth might be narrower, and maybe they have a big tongue, and all those kind of block it more.
Sometimes with our pediatrics, if they have really large tonsils, that'll help block their airway as well.
Maybe apneic.
Yeah, or deviated septum or polyps inside the nose. All those things that make it where the air won't go to where it needs to go, and is being blocked at night. Because if you're deeper sleep and you're limper overall, and your body feels like I'm not getting the air that I need, I'm not getting the oxygen, or I'm not removing this carbon dioxide that I'm trying to exchange for it, then your brain thinks that it's choking. It feels like someone is trying to kill me in my sleep, and your brain to be able to
sound like it often.
It does,
Like-
right? And your brain trying to protect you is going to put a little bit more tone to wake you up some. That way you don't die from it. And those interruptions in the deep sleep is what makes people feel all tired throughout the day. Central sleep apnea is a little bit more involved with the sensors and the way your brain is picking that up. For example, we have sensors in the major arteries of our neck and sensors on our brainstem, the part that's called the medulla. And those sensors are picking up on the pH changes or how acidic the blood gets, and that's a factor of CO2. We can get more nerdy and talk about that at length if you like. But those sensors tell the brain, I need more air or I need less air. And what can happen is if that system is off, if the sensors are off, if something's suppressing the brain, like maybe pain medications or certain conditions, neurological conditions that could be a stroke or a damage to the brain stem, then that drive to take a breath isn't there. So that means air can go where it needs to. It's not obstructive, but the brain isn't signaling that diaphragm to move to take that breath, and that's where the central sleep apnea comes from. And what makes it even more complicated is that some people could have both at once.
Yes, and that's complex sleep apnea if you're unfortunately struggling with both. The complex sleep apnea is more common in people with heart failure, correct?
That's correct, and this was an interesting thing where with heart failure, the blood doesn't get pumped out efficiently or effectively out of the heart. And what's unique is when the heart pumps, but there's that delay in that blood getting up to those receptors in the neck or the brain, then there's that delay that the brain says, I don't think I need to breathe right now. And that's where the complication is, where the brain needs to breathe but is thinking it doesn't need to breathe, and by the way, we need oxygen all the time.
So with sleep apnea, if you're a person who's sleepy during the day, if you're snoring, gasping, falling asleep frequently, then we would want to see if you have sleep apnea. And what are the options on testing someone for sleep apnea?
With anyone who have those symptoms of maybe morning headaches, morning tiredness, just too sleepy throughout the day, what else we have? Complaining of fatigue or complaining that their attention isn't so great at work or doing their homework at the end of the day.
And sometimes
Brain
we'll even,
fog.
the brain fog. Sometimes we'll throw in when we can't get other chronic diseases controlled. So when we can't get your blood pressure controlled, it's not responding to medicines. When we can't get your depression controlled, doesn't seem to be responding. Many times sleep apnea isn't just making you tired, it's really a contributor of many other chronic diseases, and it can be a struggle to get those other chronic diseases controlled.
I have a couple of patients who you wouldn't think would have obstructive sleep apnea. They're females and thinner and in their 50s, but the fatigue, like we couldn't get past it. So I said, you know what, like let me just see. And they did, it was obstructive sleep apnea, but they're on CPAPs and now they feel so much better and like don't go anywhere without them. So, there are the one-offs where like we can't get something under control, or, we've done, the bazillion-dollar blood work for all the fatigue stuff and nothing's coming back.
Right. And that's a good time to look
to see.
Yeah, so there is a lot of those symptoms that people have that they've always attributed to something else. But when they have those symptoms, yes, you should get a sleep test. We've been doing what we call a home sleep study, where someone may have a little headgear with a couple stickies and that measures their oxygen and their airflow, and they can sleep in their own bedroom. The more data we collect, the more reliable we understand what the results may be. So we sometimes will ask for 1 or 2, 3 nights in a row. For other people, we may go to a certified sleep center. Those patients will go to a place that looks like a nice hotel room, where there's a technician that kind of connects them with a lot more wires because they're getting a lot more information and data. And the technician is actually there the whole night long, not in the room, but watching on a camera, with respect to someone tossing and turning, or maybe making some snoring. When they're hooked up, you actually can see the stage of sleep. Whether it's light, medium, or deep, or dreaming sleep or REM sleep. And at that time, if someone has sleep apnea, meaning an apnea spell is when someone doesn't get airflow, it might drop by more than 50%, and the oxygen level drops. The oxygen level may drop by 4 points. You realize that if we held our breath for as long as possible, we might be able to make it go down 1. And so the technician is there watching them. So if they realize that there is something going on, that they may implement any kind of therapy at the moment. So people who may have more complicated medical history, like heart failure or high blood pressure, or other conditions where they need to be watched, probably in the clinic sleep study would be best for them.
And as Dr. Lacayo said, there's someone watching. So if we're concerned about things like restless leg syndrome, we're going to be able to pick those kind of things up with the sleep technician. High risk people, we really don't want to do the home study. The home study is great because it's easier. It's from the comfort of your home, and most people will prefer that. But it's not as detailed. It's really looking at how many times do you stop breathing, what is going on with your oxygen. And can pick up then things like also your pulse rate or other things that maybe, some basic information, but it's looking for if you stop breathing or not. All the other things, and we're not looking at your brain waves. We're not looking at whether your brain is giving a message to your lungs, and that needs to be done in a sleep center. And so there are definitely times when it is most appropriate to do the sleep test in the sleep center. And so then we do the sleep test and we get this information. And so someone's coming back to discuss their results of their sleep study. What kind of information do you get from an in-lab sleep study, and what kind of diagnosis can be made from that?
The in-lab study actually tells you where you are in sleeping. So if you go to deep sleep and something happens and you wake up, that is going to be an episode that woke you up, because you have wires that are measuring your oxygen and measuring your airflow, that if your airflow drops and your brain wakes up, all of these are being recorded at the same time. We can say that this awakening was due to the airflow dropping, and that would be an apnea spell if meeting certain criteria. The other aspect of it is if you have little connectors stuck onto your legs as well, because another interruption would be what we call periodic limb movement disorder, where people will kind of their legs will twitch on their own. Sometimes it feels restless and they got to move their legs at night, and that restless leg syndrome, a little bit different than the periodic limb movement disorder. So if your legs are twitching, just twitching on their own, and that kind of like nudges your body in the middle of the night, the brain will wake up from that too. So that could happen if it's 15 times an hour, then we call it abnormal. We might have to treat that limb movement disorder. And some people just wake up. So if their brain is waking up in the middle of the night and it wasn't due to the airflow, or it wasn't due to their body just twitching on its own, then we realize it may be just a maintenance insomnia, that they can't stay asleep deeply on their own. And because we're seeing them wake up throughout the night. We're seeing if that waking up happened immediately after low airflow or after a leg twitch. And with that maintenance insomnia, the treatment would be different. It would be trying to figure out how we can make people sleep more and more consistently at night.
And so when someone gets the results from their sleep study, what are our treatment options?
For obstructive sleep apnea, we often talk about 4 treatment options. If someone has mild, meaning they may have 5 episodes an hour, versus moderate, that may be 15 episodes an hour, or severe, that's 30 episodes an hour, I think we probably all have seen patients where they might have been in 100 episodes per hour. I mean, 30 episodes per hour is once every 2 minutes. Something's happening. It's like someone's choking you every 2 minutes.
You must feel horrible.
Right.
Like
Absolutely.
you have to feel horrible.
Absolutely. And so those are the things that we're trying to pay attention to, is how many of these episodes that you have per hour, and then the treatment for it. If someone has mild sleep apnea, our protocol, our first step is sleep apnea is usually worst when people are laying on their back. When they're laying on their back, everything falls back in the airway. And so if we can get them to sleep on their sides, it would be better. So we'll call it sleep position therapy. When I was in the Air Force, treating people for that, they would say, I just need to make sure I sleep on my side. I was like, yes. So, of course, they'll take their backpack, put a basketball in it, and wear it all night long, because that would make it where they never would roll on their side. For other people, it could be some more pillows or body pillows, you name it.
I've told patients before the advice of sewing a tennis ball into the back of their sleeping shirt, and they always look at me like, are you serious? But it is also a recommendation that when you roll onto your back, if you have something that kind of pushes you back over, then you can stay off of your back.
Right. Other people married their device, so when they're snoring and making sounds at night, their spouse is kind of hitting them and pushing them over. The third step we'll talk about, like, surgery. And surgery, it has a long name that we call UPPP for short, is trying to open up the airway surgically. If you have large tonsils, taking them out has been a treatment. If your septum is very deviated in your nose, maybe straightening out could be a way of getting more airflow in there. Although the air through the back of our throat is what's most important when it gets obstructed, and not necessarily through our nose. Surgery of that type in adults is quite painful, so it's not necessarily one that I would be recommending people to consider first. Because surgery can open up the airway, it might be best for people who may need a few years of a larger airway. Because what can happen is, things grow back. And as things grow back into place, some obstructive sleep apnea may recur. And then the gold standard is CPAP, or positive pressure. That often is that if we put more pressure into our airway, it's going to keep it open. To do so, we have to make a seal, and so that's where the masks come into play.
Yeah, and everybody wants to fight us, and I'm like, they'll fit you. There's different ones, but usually once patients use them and see the benefit from them, you can't take them away from them. They feel so much better.
Right.
Yeah, there probably is a bit of an uptake. I think the first 2 weeks is most important, where people will use it. Once they use it, many people, as you've heard, say, I feel like a new person again. And then there's no way that they're going to sleep, even if it's a nap during the day, where they're going to sleep without their device.
Now, central sleep apnea requires a BiPAP, correct, versus a CPAP? Or am I incorrect?
That's where it gets a little bit more complicated, where we're using a CPAP, and the CPAP stands for continuous, making it where the same pressure setting is throughout, breathing in or out. A BiPAP has 2 levels, so it has one level of breathing in and another level of breathing out. Sometimes what can happen is with CPAP or BiPAP that you're treating the obstructive sleep apnea, but then the brain, remember those receptors we talked about earlier? The brain says, well, I have all the air that I need, so I can just stop breathing now. And so some of the central sleep apneas will come out that way. And so the ultimate treatment for that is going to be a much more complicated and a lot more expensive machine, I've heard, where it actually, once it detects a person who is not breathing, will kick in and make sure it gives them a breath set to a certain rate.
What is that machine called?
Gosh, we call it, I can't remember now.
That's
Is it a
okay,
special
yeah. I was
air
thinking-
servo ventilator?
Okay,
I was
wow.
thinking it was a
Wow.
BiPAP, but I knew it was different. I knew they had to be set
Okay.
differently, but I didn't realize it was a completely different machine.
Oh, that's super important to know, though, that you've got to identify the central and the people who are at risk of it, because
Well,
the
and
treatment
that's-
is going to vary.
Well, and that's one of the things when patients are using it, and like, especially for CPAPs, and I'm not sure if you have patients with central sleep apnea that follow up with you, but like a lot of times we want to see those patients within 30 days after they're using their device, because it, however, I'm not a technological person, but somebody somewhere in the cloud of CPAP machines is keeping up with how they're doing on the machine.
Right.
And so if someone were to have, both central and obstructive sleep apnea, the CPAP alone may not be enough. So that's why following up is so important after you get
Right.
those devices.
To assure that their apneic episodes have decreased.
Yeah.
It is, and I think for some of the patients who may have obstructive sleep apnea diagnosed and get started on a CPAP or a BiPAP machine, some people say that the BiPAP is just more comfortable for them, and therefore you get more efficacy and utility that the patient is using it. That if maybe they feel like they're hitting a wall, I feel better, but not as better as you promised me, doctor, then in that case, it's like a consideration for going back to the sleep clinic and seeing if maybe there's a central sleep apnea there. Because that ASV machine is a little bit more complicated. It's basically like a home ventilator that at that time, the pulmonologist is usually the ones that would defer to get that patient started on it and monitored.
Okay. I think it's really important for people to realize, and I find myself telling people this a lot, that when you have obstructive sleep apnea or central sleep apnea, it's worse than just sleepiness. The overall effect on your body can be really profound. Like we mentioned before, it can make it difficult to control your sugar, to control your blood pressure, so other chronic diseases can really get out of whack. But it also puts you at risk of things like heart arrhythmias. And one of the reasons that we like to do sleep studies is when someone has a new diagnosis of AFib or an arrhythmia, and we say, well, maybe sleep apnea is causing this. And so we'll then look for an underlying issue that may be contributing to arrhythmias. And weight loss. A lot of stress hormones are released when you're not sleeping well. And so people will struggle more with obesity. And sometimes people will say, well, I'm just going to lose weight because won't it help my obstructive sleep apnea if I get down to normal weight? And it will. Many people can. If you've lost a lot of weight, you can repeat your sleep study, and we may find that you, in changing your neck size, have decreased your apneic episodes, and maybe you don't have obstructive sleep apnea. But sometimes by nature of not treating it, you can't lose the weight. And so I'll often encourage people, we'll treat it, lose the weight, and then we can come back off the treatment if you no longer need it. But there are a lot of consequences that can come from undiagnosed and untreated sleep apnea. There's a lot of the population that has sleep apnea, and a lot of those people who aren't diagnosed. So certainly, if you would like your spouse to stop snoring, it is not a selfish act to have them get a sleep study. It may actually save their life and help them in a number of different arenas. Thank you so much for helping us understand more about sleep apnea, and that it's a bit more complicated than what we tend to think, and how important it is for us to diagnose and treat that in people where it exists.
All right, thanks.
We like to leave you on a good note. So here is today's Tell Me Something Good. Something great is gratitude. You've heard me say it in our podcast so many times. Gratitude changes our vision of the world. Being thankful for what we have, focusing on the good and not the bad, changes our lives. So practice gratitude this next week. Look for something every day that you can be genuinely thankful for. Thank you for joining us, and until next time, take care of yourself.